So today, I'm very happy to be able to talk to you about a subject that's near and dear to my heart, having been in practice for 30 years. And want to talk about good fences. I want to talk about boundaries in rural practice. Integrity is one of the domains of competence in rural practice, and negotiating dual relationships is a competency within that domain. I have this picture that I really like because it shows me a lot younger. I have no gray hair, and I still have my mustache, and I don't look quite as much like Robert Frost as I do now. And it reminds me of what I really enjoyed about rural practice, the continuity of care of families. I delivered this little girl, cared for her up until her middle school years. She probably has kids of her own now, but I've since moved from clinical practice into an academic position. That's really what I enjoyed. And I enjoyed those 30 years of practice and have no regrets because I built and maintained good fences. I crossed them in healthy ways. And I hope that that will be the case for all of you in practice as well. Here's a really good urban fence, but here's an even better one with razor wire at the top. It keeps people out, keeps people separate, and crossing it is quite hazardous. Here's the kind of fence I'm thinking about when I put together this talk. And this is what Robert Frost was thinking of in his poem, Mending Wall. The kind of fence that Robert Frost was talking about is one that needs mending from time to time. The elements tend to knock it down. And good neighbors, as you probably heard in the poem, Mending Wall, really work at maintaining that fence. Although the two people in the poem go back and forth about that. Robert is more the urban point of view, and his neighbor is more the rural point of view. Although you could argue it the other way. Many rural walls are actually meant to be crossed. Here's one that has an opening. There are gaps rather than gates to allow healthy boundary crossings. And as a rural physician, it was really rewarding for me to care for my friends and neighbors in a rural place. And although an urban place, it may be easy to avoid conflicting relationships known as dual relationships. In a rural place, they're unavoidable. Crossing the usual boundaries around the patient-doctor relationship happens every day. I like to say that life in a rural place is life with fewer people but more relationships. Where my neighbor might be my patient, they might be my son's soccer coach, they might be my daughter's piano teacher, I might go to church with them on Sunday. And so these dual relationships, although very enriching to my life as a rural person, as a physician can be problematic. For rural physicians who wear different hats and play different roles, interacting with the same individual in multiple contexts happens very frequently. And someone has said that to completely avoid dual relationships in rural practice is to either have too few patients, or if many patients, too few friends. And it turns out that's true. It really is somewhat of a balance. Our clinical psychologist in the rural residency I directed for 15 years had always been taught that dual relationships were prohibited, and had a lot of difficulty being the clinical psychologist in a rural residency. But there, even she learned the benefit of healthy crossings. And it became a time of really active interaction among us and a learning edge for myself as well as the residents who attended our residency. The very nature of a dual relationship in clinical practice implies that the physician has some personal investment in the relationship beyond his or her professional roles. So you have a professional relationship, doctor-patient relationship, and you have this other relationship. And potentially it creates a conflict of interest. And that's what we're going to talk about today. There are a lot of benefits to dual relationships. And you may already know these or have experienced these as residents in rural programs. But trust is a really important part of the doctor-patient relationship. And if I know you as my neighbor and I see you in other places in life and know you as a person of integrity, it certainly does contribute to trust in the relationship. There are benefits in understanding. I may understand you better because I'm from your same town. I may give you more culturally appropriate care, personal attention. And transparency, as some folks have said, is in a rural place, is living in a glass house. So people can see me when I shop at Kroger. They know how many bottles of wine I buy, if I buy any at all. And it's hard to not be a person of integrity in a rural place. The last benefit, however, is a bit problematic because it is rewarding, personally rewarding, to care for friends and neighbors. And that's the problem. As we look at the pitfalls of dual relationships, lack of trust is often a problem because if I'm your neighbor, how do I know you aren't going to tell our other neighbor something that happened in the exam room? I may make incorrect assumptions. I may think I know this person really well because they're my friend. And so I just assume things that aren't true rather than critically asking them the questions I need to ask in the moment relative to their chief complaint. I may give culturally limited care because I make assumptions based on stereotypes. And transparency is good in some respects, but when it comes to HIPAA and confidentiality between doctor and patient, it's a problem. I had a patient who was a member of our hospital board of trustees, came in to see me for a urethral discharge after a trip to Mexico for a business meeting where he had had a one-night stand and contracted gonorrhea. That was really dicey. In fact, he came to see me rather than his family doctor who was in my group practice because I think he didn't want his family doctor to know and in some way let his wife know the situation. It's also possible to make referrals late and keep a friend from seeing a real doctor. I'm tempted to want to keep the patient as my patient. I want to do what's best for them. And I may inflate or conflate my own abilities. Or if I give them advice over the dinner table some evening or out at a 4th of July picnic, that may keep them from actually going to a real doctor and sitting in an exam room. I had a cardiologist friend who over dinner one night told his friend across the table that he probably ought to take the purple pill at that time, Prilosec, for some heartburn. 2 to 3 days later, he showed up in my office. He was my patient, and he had had a large anterior MI and subsequently developed a cardiomyopathy. So here a cardiologist made a decision in a friendship kind of way that ended up causing him to make a mistake he wouldn't have made in the exam room with his stethoscope on. And then finally, loss of work-life balance. I had a friend who actually had to change churches because every Sunday morning people would approach him with rashes and such, and he'd even take people into a Sunday school room and to examine them. He couldn't worship on Sunday morning. and had to change churches. Here are some other pitfalls. Compromise quality of care by compromising objectivity, and the story I told illustrates this as well. Unnecessary and potentially harmful intervention, doing more when in fact you should do less. It's not always good to run every test in the book, as you guys are learning in your education and training. And unfortunately, in some cases, dual relationships are physician-centered rather than patient-centered. It's easy to get there when the relationship is so rewarding to you as the physician. Here's one of the competency domains for rural practice: integrity. And in addition to demonstrating authenticity with patients and behaving in a way that's true to yourself and to others, negotiating dual relationships with integrity is a really important competency. So what's a boundary crossing or a boundary violation? Well, a boundary crossing becomes a boundary violation when the crossing is clearly illegal. And the case of the doctor having an affair with her patient is clearly a boundary violation. But in other cases, the crossing may be unethical, compromises the patient's autonomy, leads to harm, or violates some principle of justice. There are legal considerations and professional codes that govern this. Sexual behavior is never diagnostic or therapeutic in the doctor-patient relationship, and in Ohio at least, can result in your losing your license. I'm not sure that's true in absolutely every state, but I'm pretty sure it's true in most states. Controlled substances should only be prescribed with detached professional judgment, and it is illegal federally to prescribe narcotics to yourself, to an immediate family member, son, or spouse. And there are professional codes that strongly discourage care among family or friends. But in a rural place, you may not have that option if you're the only doctor, for example. And so you have to, in a rural place, or even in an urban underserved setting, you may have to cross boundaries that someone in a suburban location that's overserved wouldn't have to worry about. So I use 4 questions, 4 strategies, and 4 tactics to address these pitfalls and keep myself out of trouble. Let me just get ahead here to my questions. So first question I like to ask myself is, would I have difficulty sacrificing one relationship for the other? If I have a dual relationship and I don't want to give either one of them up, that tells me that I am conflicted, that I have a vested interest in both. And if I can't give one of them up in the interest of the best medical care possible, that's going to be a problem. That's a red flag. Secondly, do I gain something from this relationship in addition to financial compensation or the simple satisfaction of doing a good job in my role as a physician? If so, that's a red flag that this could be at least a boundary crossing. Am I too close to probe this person's intimate history? I may be reluctant to ask a complete sexual history or even a spiritual history on someone who goes to church with me. I may have difficulty breaking bad news. And again, if I find myself having difficulty in these areas, that's a sign that I've at least crossed a boundary and at least am in a relationship that's dual. And then finally, does this person expect, or is this person receiving something special? I had one of my doctor friends' daughter come in to see me for after-hours care one night and was absolutely furious that I charged her for the visit. It's one of those things that if people are expecting something special because I'm your best friend, there's a tendency to violate rules, to do things that you wouldn't otherwise do for patients, and end up actually causing harm. So here are the 4 rules or general strategies. I think it's important to name a relationship as a dual relationship. Be aware that you've crossed a boundary. I like to use the stethoscope rule. I don't have my stethoscope on right now. And so if I'm in a Kroger aisle, that's not the time to be doctoring. It's at least an alert to me that, that I need to cross the boundary carefully. Monitor the relationship regularly. Is this still a healthy dual relationship? Not only monitor it yourself, but remain accountable to staff and peers and to the patient, always giving them the opportunity to opt out. And then finally, 4 tactics. I think it's important at the beginning of a relationship in rural practice that you negotiate and set some explicit boundaries. I'd be happy to be your doctor, honored that you'd come to me for care, but only on the following conditions, and then go through the things that, that are important to you and keeping yourself healthy and crossing boundaries. You know, make a rule that either way, either one of us can bail from this relationship at any time that we see it getting in the way of good medical care. Keep the relationship patient-centered. You know, this has to be awkward. What can I do to make it easier? Practice transparency. I'm comfortable making a recommendation. I'm uncomfortable making a recommendation in your case, so I need another opinion. And be honest about that. Be quick to refer to another physician locally or at a distance. And then finally, document, document, document. And I want to make the point here that this is not a legal issue, documentation. This is a healthy boundaries issue. Number one, documenting something reminds yourself that it is a potentially conflicted relationship. And secondly, it helps you remember later what it is that you had negotiated around building a good fence or mending a wall between you. So hopefully with these 4 questions, 4 rules and 4 tactics, you'll be off to a good start in negotiating dual relationships in a healthy way in practice.